Good afternoon, respected chairpersons, delegates, friends. I ask you to close your eyes, I'm sure you can imagine, you can hear ultrasound, you can see two tall columns of Erector Spinae. We've heard so much of Erector Spinae and ultrasound, so let me just take you through this brief presentation of how Erector Spinae, which everybody is talking about, the new kid on the block in town, and how it has been used from anywhere from the head, and now we have been using it for the past couple of years for even lower limb surgeries. So, for example, take this case. This happened with us a couple of years ago, maybe last year, I don't know. 67-year-old male with periprosthetic refracture. You can see so much of hardware already inside, and there is a fracture. So the surgeons planned an open reduction again with bone grafting was planned from the ipsilateral iliac crest. Or similar case where the fracture is lower down here in the tibia, or you can also consider this Charcot foot requires, what you call arthrodesis of the ankle joint with bone grafting. So what do you do? Normally you would do at least 2 to 3 different kind of blocks to give a complete pain relief. So various combination. If you're not doing epidural, then you'll have to combine at least 2. So I'm just going to flip through these slides. You've already gone through the anatomy of the various layers of the back, the erector spinae muscles, and lower to them the transversus spinalis, the multifidus, and all that. Now, to study the clinical anatomy of thoracolumbar fascia is extremely important to understand all the newer blocks that are being described, the QL, the erector spinae, retrolaminar, and what have you. So pictorially, if this is the vertebral body, this is the spinous process and the transverse process, you would perform a retrolaminar block here, you will do an ESP block there, and you will do a thoracic paravertebral there. Under ultrasound, this is how this would appear. This is a continuous lamina, and while these are the transverse processes. Now, as has been explained by Professor Barrington, this is how, if you deposit the local anesthetic, it will just trickle not only ventrally, medially into the neuraxis, maybe some of it will go down to laterally to the intercostal spaces as well, and of course it will travel up and down. So this is, you can see, imagine how the vertical spread will occur if you deposit the drug there. So if you do quadratus lumborum there, or you do the ESP there, they're kind of, in the same fascial plane. So it is still early days, but we don't know exactly how these blocks work, but we definitely know that thoracolumbar fascia has a role to play. So this is how the ESP spread is described. If this is the ESP and your needle is coming from the back, if you go too deep inside, the sheath is tethered to the transverse processes at various levels, so your block will be restricted. So you have to be careful to stop short, so that it is enough craniocaudal spread. So this is how what people tout or what people claim how the block acts, that it is proximal paravertebral block. But then when we come down to the lumbar level, lumbar ESP block, there is no paravertebral space comparable to thoracic paravertebral space outside the pleura. So some people say that lumbar ESP is actually a lumbar plexus block. But then if you look at this paper which came out, where patient already had a spinal cord stimulator in place for a complex regional pain syndrome. He used to have periodic aggravation. Lumbar plexus block was given to this patient, had no effect in ameliorating the pain. And then this patient was offered an ESP block at L4 level, which caused pain relief. And with the images, they could not show any spread to lumbar plexus. So that means there are some other routes or methods or mechanisms of action. So again, coming to these complex cases, if you just keep in mind the various dermatomes and aim for the middle of the dermatome that you want to block. So it will be like this. See, this is, I'm aiming at L1. You can see the pleural movement there. If you saw the transducer, which is a low frequency curvilinear probe coming down from lateral to medial side. You saw the rib there. I don't know whether you noticed it. I'll play it again. I'm sorry. So here, if you see, this is the rib. I can't make out, it's too dark. I'm sorry about the quality of the video, but it appeared fine on my laptop. But anyway, so if you come down to the further lower down, that was at L1 for hip surgery, which required iliac crest bone harvesting as well. Now this is for the lower down complex knee surgeries, where you have to aim for L3, maybe L4 level. And so once you have determined the level after traveling up from the sacrum level, you can see how the spread of local anesthetic, how the erector spinae muscle is getting lifted off. So this spread is, you can maybe make out, it's a little different from what you find in the thoracic level because of the thickness of the muscle at this level. And you can see longitudinally it spreads so nicely. So what I'm trying to show you here is that there is a breathing sign as described by Professor Macaire. When you are in the right plane, the muscle seems to lift off and then collapse again. The space keeps on expanding and collapsing. That means you are in the right plane. Thank you very much. And you can also put catheters there, and that is what we routinely do, and they work very well.